we go to our third type of nephrotic syndrome. Our first, minimal change. Second, FSGS. Let's talk about our membranous glomerulonephritis. Membranous. As the name implies, it'll be the membrane that'll be affected. And depending as to which demographics you're dealing with, well, some would say that this is the most common that's found in adults. But be careful here. Whereas then other demographics and populations and such would say that FSGS is in adults. Well, both are true. You have to know both. If you're dealing with Hispanic population and you're dealing with African American population, then you're looking at FSGS in adults. You're looking at FSGS being quite common, and we talked about HIV patients. If it is an adult, 40-year-old, approximately Caucasian male, then you're thinking at membranous glomerulonephritis. Are we clear? Now, once you get your patient down, and this patient is a Caucasian male, approximately 40s coming in, and they're presenting with what? And generalized edema. They'll have greater than 3.5 grams of protein that's being lost. You have lipoid accumulation. Then you know this is membranous. Maybe may not have hypertension. High incidence in teenagers, young adults. There is going to be complete thickening of the membrane. Membrane. What you do not see here is proliferative. Is that clear? At some point when we get into MPGN, completely different diagnosis. Students tend to get that confused. Don't do that anymore. So on H&E, you'll find entire glomerular membrane, which is now then become thickened. Ultraviolet microscopy is important for you to understand. Okay, now, let's say that you have the membrane that's being involved. Okay, great. And at the same time, you also find that on the side of the podocyte, where are you? Urine side. Underneath that podocyte, you end up finding deposit. What kind of deposit would you call this? Subepithelial type of deposit. That you'll have to memorize, please. So here, in membranous glomerulonephritis, what's amazing and important clinically is the fact that not only are you going to have membrane involvement, intermembranous deposition of immunoglobulin, what I say, immunoglobulin, but then you also have subepithelial deposit. Now, why is that important? Because you're reading a clinical vignette and you've been posed with questions, okay? And if you weren't paying attention, then maybe perhaps you got these two diagnoses confused, or these three, really. Watch this. I want you to tell me in your head, you're thinking, three different conditions. One is membranous glomerulonephritis, the other one is PSGN, post-streptococcal glomerulonephritis, and the third one is Goodpasture. Why did I bring up those three? In membranous, are we affecting the membrane? Absolutely, hence the name. On light microscopy, you find thickening of that membrane. In Goodpasture, is it possible that you find thickening of the membrane, or would you find involvement of the membrane Goodpasture? Yes, you would. So now you have two conditions in which a membrane is involved. How can you tell the difference? Hold on. In membranous, take a look at this. You must memorize subepithelial deposit. In Goodpasture, do you have such immune complex deposition? No, you do not in Goodpasture. That's a type 2 hypersensitivity. You do not have such immune complex deposition. How can you confirm that? Immunofluorescence. Interesting. Immunofluorescence on Goodpasture, what have you seen? Linear pattern. If this is subepithelial, then what's my pattern? Good. We have granular pattern. What was the third differential that I gave you? Post-streptococcal glomerulonephritis. Why did I give you this one as being a differential? In post-streptococcal glomerulonephritis, where is my deposit? Where is my deposit, please? Subepithelial. Where's my deposit here? Subepithelial. How can I tell the difference? Obviously history, but say that you kind of ignored the history and all that you're looking at is ultraviolet microscopy. How can you tell the difference? It's the fact that here in membranous, you have membrane and subepithelial. What about post-streptococcal? Only subepithelial. Is that understood? So, the three major differentials, you want to make sure you come back and review what I just said here, and you're clear about what to clinch clinically so you make the diagnosis. Membranous glomerulonephritis has both membrane involvement and subepithelial. Post-streptococcal, only subepithelial, obviously coming from the skin or from the pharyngitis. And then we have Goodpasture, which is only the membrane. Are we clear? Only after this, and you feel solid and comfortable, should you move on? Now, there is something called spike and dome. You won't really be given that, but just so that you know, the spike represents in between the immune complexes. You'll have the intervening glomerular-based membrane in between the immune complexes. What does the immune complex look like? It looks like a dome, hence a spike and dome description. And granular deposition? Sure. Why? On what? And by the way, what kind of biopsy pattern? Good, immunofluorescence. And here you find IgG or C3, and it'll be what kind of deposit? Subepithelial. Membranous glomerulonephritis. Here, if you take a look at the left light microscopy, you'll find the entire glomerulus has been involved, and you find thickening of that membrane. Point number one. Point number two, the figure on the right with the electron microscopy. First and foremost, is the membrane involved? Yes, it is. Who's your patient? Most likely a 40-year-old Caucasian male, adult, obviously. And that deposit, which is a dark deposit, well, that membrane looks messed up. What side of this? Looks like it's the foot process. Right and above. So underneath the foot process is a subepithelial deposit. That is the dome. In between the immune complexes, or the domes, would be the intervening basement membrane. There is no proliferation here. Membranous glomerulonephritis. Here, on immunofluorescence, this is a picture in which we're seeing our granular pattern. The cartoon then represents membrane involvement, and also you have issues with subepithelium. Would you perhaps find foot process being effaced or fused? What is this? Nephrotic syndrome. What does that mean to you? Cytokines. So therefore, what kind of effect may cytokines have on your podocyte? Fusion. So as a general rule, fusion of your foot processes could be found in all nephrotic syndromes. Membranous, thickened membrane. Spike appearance would be the membrane. The dome, in fact, would be the subepithelial deposit. Under membranous, important associations you want to keep in mind. Usually primary, could be secondary. Now, secondary, be careful. Drugs. By drugs, I don't mean heroin. If it was heroin, you were thinking about FSGS. If it was HIV, you were thinking about FSGS. The drugs here, maybe chelators, penicillamine, maybe antihypertensives, pills, or anti-inflammatory. Prescription drugs. Malignancies are a big one. Lung, colon, melanoma, membranous, SLE. Stop here for 1 second. Do not breeze past this. SLE and its prototype that we have discussed is which one? Type 4 classification. 1, 2, 3, 4. Give me a nephrotic mixed picture that has 4 letters in it. DPGN. What can it deposit there? Subendothelial. You've heard of wired loop. This is 10% of the time with SLE could have membranous. I told you we would come back and then rediscuss this. Well, here we go. So if you find SLE patient, double-stranded DNA, and subepithelial, this is membranous. Is that clear? Infection, big time. Hepatitis B, hepatitis C. Be careful, though. This is membranous. The reason I say be careful is because with hepatitis C virus, oftentimes associated with a clinical manifestation called cryoglobulinemia, and that cryoglobulinemia may actually may give you a picture of what's called MPGN. We'll talk more about that later, but I want you to give yourself some important secondary causes. And metabolic, maybe perhaps diabetes mellitus. Prognosis often progresses and rarely responds to steroid therapy. Can progress to end-stage renal disease and may be associated with renal vein thrombosis. Renal vein thrombosis, not artery. Is that clear? So if it's renal vein thrombosis, and if it's further distal, especially let's say the left renal vein, pay attention, left renal vein. I want you to move from the kidney towards your inferior vena cava. Good. As you move from the left renal vein, there goes my blood. All of a sudden, there's thrombus. And all of a sudden, what should be anastomosing, the left gonadal vein. You see what I'm getting at now? Say there's a thrombus formation, left renal vein, and I cannot move towards the inferior vena cava. and you are now blocking the left gonadal vein. In a male, what do you end up having? Bag of worms? What's this called? A varicocele